well. So welcome to the Health Research Institute seminar series. To start off with, I want to acknowledge we're on the unceded traditional territory of the Lheidli T'enneh here at UNBC. And if there's others online that would like to share where they are located, please do that in the chat. If everybody just takes a minute and just reflect on what it really means to live here, work here, and have our lives here on this beautiful land. So I guess moving through this, our Health Research Seminar Series committees, we have Leanna, myself, Kendra, Rihanna Robinson, and Bree here as well, who has helped coordinating the series this year. And of course, a big thank you to all our contributors and sponsors. So this is truly an interdisciplinary seminar series. We have the School of Health Sciences, School of Nursing, School of Social Work, Psychology Program, Northern Medical Program, and our financial sponsor, Sun Life. So just a reminder of our upcoming seminars. Our next one is on December 7th, the last one of this year, where Jackie Pedersen will be here to speak with us. So last week, we got to have a panel discussion about partnerships between UNBC and Northern Health. And this week, I was excited to see that our speaker is going to talk about community-driven partnerships in health research here at UNBC. So please join me in welcoming Dr. Vivianne Josewski, who is an assistant professor in the School of Nursing. So she just joined the School of Nursing last year in 2022 as a white settler. Dr. Josewski grew up in Germany, where she started her career as a nurse. And then after immigrating to Canada, she pursued a career in academia. She did MSc in Population and Public Health, as well as a PhD in Health Sciences from Simon Fraser University, and then came to UNBC, where she also has partnerships with the National Collaborating Center for Indigenous Health and the Health Arts Research Center with the Northern Medical Program. So I will now hand it over to Vivianne to tell you more about her research.
Kendra.
Okay. Just switch. That should be fine. Wonderful. So thank you. It's an absolute pleasure to be here today. And oh yeah.
I just have to stop sharing the previous one.
Oh,
I'm sorry.
yeah, no, I can stop sharing
For the people online.
Yeah, absolutely.
There. So, I'm supposed to be up there to help you with that. So sorry about that.
No worries at all. Is that all good now?
Yes.
Okay, perfect. Yeah, so thanks for the introductions, and thank you for inviting me. I'm very pleased to be here today and have the opportunity to talk with you and hopefully have an engaging conversation at the end about how Indigenous-led and community-driven research partnerships can advance meaningful reconciliation in healthcare. I also, I guess, in the spirit of truth and reconciliation, I want to just take a moment again to say that just to recognize we are all meeting here today on stolen land, on unceded traditional territory of the Lheidli T'enneh. And I also want to acknowledge the territories from which other people might be calling in from that are joining us today virtually. I think it's really important to have the conversations that we're having here today, considering that Western healthcare has only really limited success in addressing the needs of Indigenous peoples and addressing those inequities that exist due to ongoing racism at the systematic level, as well as at the individual level, is something that requires transformative change in the healthcare system. And I think Indigenous-led community-driven health partnerships play a vital role in addressing those inequities. So with this, I want to start the, there we go, the presentation for today. And just a very broad outline for today's conversation. I just want to start with situating myself as a white settler and immigrant person living on stolen land in what is now known and called Canada. And also want to situate myself in relation to the research I'm doing, which is in Indigenous health. And then I want to move on and introduce and discuss three really unique partnerships with Indigenous communities that two of them are still ongoing, and one is in relation to my PhD research. And then at the end, I hope we can just kind of reflect together on some of the lessons learned and engage in hopefully an amazing discussion around how to advance reconciliation in healthcare. And if you have any questions about how to do this in your own research, I really look forward to hearing questions. So, for white settler researchers who are engaged in Indigenous health research, such as myself, really reflecting on my motivations to engage in this kind of research, in my perspectives that I bring to the research, like how do I look at knowledge, how do I understand research collaboration, what kind of approach do I even take to research, are all really important questions to consider, just to make sure that as we're engaging in research, we not inadvertently reproduce relations in research that might be recolonizing in their impact. And that's really important because, as Linda Twary-Smith reminds us, research has had a very violent history with Indigenous communities. And for many Indigenous communities, research is a very negative term, one of the dirtiest words that there is. So in recognition of that, I think we have a responsibility as non-Indigenous researchers to really start decolonizing our minds, our hearts, and that's something that comes from Margaret Kovacs, who is another Indigenous scholar and researcher, who has talked about the importance of exploring your own beliefs and values, about exploring your, in this case, my own whiteness, and exploring how power imbalances are perpetuated in institutions like UNBC, institutions like the healthcare system, in recognizing that we are part of been educated and I continue to work as part of an institution that has historically and continues to silence oftentimes Indigenous voices, that has misappropriated Indigenous knowledges and also misrepresented the cultural other. So how to deal with this, reflecting on it, being critically aware of your own positioning and impact is one way of doing this, but it's also really important to take action. And in my case, I've been taking action by developing relationships with communities, getting to know communities, engaging in Indigenous scholarship, like reading Indigenous people's contribution to the literature, to the science, and also drawing on critical and Indigenous perspectives in guiding my approach to research. So some of the theoretical frameworks and perspectives that I'm drawing on as a scholar is anti-racist and anti-colonial perspectives, feminist perspectives, specifically Black feminism, intersectional theorizing, as well as Indigenous anti-colonizing perspectives, and more broadly speaking, I think anti-colonial, anti-racist theories. And what those theories can do for us is they can really help us to foreground Indigenous voices in our research. They can help us to think about how to decenter very dominant narratives and create a space where Indigenous people, or those who have been marginalized in the past and silenced because of how they have been positioned, actually can speak up for themselves. Such perspectives also really emphasize the importance of lived experience to begin with, and they allow us to have a structural analysis of things like racism, gender, violence, but also like things like cultural safety. So usually cultural safety is something that we look at the level of healthcare, at the individual level, at the level where healthcare providers interact with the provider. But those kind of perspectives help us to think about what other structures and processes, policies, practices need to be in place to enable culturally safe care. So drawing on those kind of perspectives, I really try hard to continuously reflect on my own privileges, especially those that are unearned, and to create a space where I can be an ally. So not to talk for or on behalf of people, but really create a space where I can work alongside Indigenous communities, where they can exercise their own human agency and use their own voice to tell their truth. So I think that the 3 community-partnered health research projects that I want to introduce to you today exemplify this in various different ways. And the first one I want to talk with you about is, as I said, my doctoral research, which was entitled Moving Towards Cultural Safety in Mental Health and Addictions Contracting with Urban Indigenous Providers. And the second one is a study that's still ongoing. It's called Indigenous Methodologies for Telediabetes and Obesity Care in Urban Indigenous Communities, in short, IM2 Care. And the last project I want to introduce to you shortly is actually one that's going on here at UNBC in the School of Nursing, and really looks at co-creating with communities, specifically Indigenous communities here in the North, a strategic framework or vision for how to decolonize nursing in ways that is responsive to the needs and priorities and context of First Nations, Métis, and Inuit peoples living in the North. So this, as I said, was my doctoral project. And it's a project that was trying to better understand contracting, so contractual arrangements, financial arrangements, with urban Indigenous community-based providers. And the reason that I was looking at this topic, which I never thought in a million years I would be looking at, because I didn't know anything about it, is because it came from my master's research, which was a small exploratory study with, I think, 4 organizations, also Indigenous, in one health region in BC. And it was just exploring how mental health reform had shaped access to culturally safe mental health and addictions care. And what came out of the study, one of the things that came out of the study is that how contracts were designed or are designed really shapes how healthcare can be delivered. And oftentimes it created barriers, unintended barriers. So hence my interest in my doctoral research to really build up on this and look much more closely at contracting. And to do this through the eyes of urban Indigenous providers, that was the goal. So I set out and I partnered, I built up on my relationships that are already established with communities, but also expanded them and ended up working with 8 different urban community-based organizations across BC, which included 7 Indigenous. And when I say Indigenous, I mean they had a board that the governing board was predominantly Indigenous, and 1 non-Indigenous organization, which predominantly, or like a lot of the people there served, actually identified as Indigenous. So was included as well. I also partnered with 2 regional health authorities in order to kind of get access to the contracts and kind of take a look at how those contracts were articulated and what the conditions were of the funding and how the funding was distributed. And beyond that, I also looked at other kind of calls that were out there as well. Because there are constraints when you do a PhD or a master's, it is an expectation that you do this work independently, and it's a lonely journey at times. So you have to become creative of how you actually apply your collaborative methodologies and still kind of abide by the rules of post-secondary institutions in terms of how to get your PhD. So in this case, I was actually working with an Indigenous advisory to have those kind of perspectives and form my research from the beginning up to the very end. In addition, I made decisions to use methodologies or methods that highlighted lived experience. So I worked with in-depth interviews. And I made a decision that I was looking for Indigenous perspective and experiences predominantly. And I'm glad to say that the majority of people I did interview actually identified as Indigenous. And that wasn't an easy thing to achieve because the sector isn't obviously, not everybody who works in the Indigenous non-for-profit sector is actually Indigenous. And then the final part of my research also included a critical document review in order to contextualize the things I heard from people more deeply in funding calls and contractual arrangements as another source of knowledge, even if it wasn't at the center of my research. So my analysis really applied a multi-level analysis. So I wanted to look at macro, meso, and micro level processes and practices. And for that reason, I also interviewed people, Indigenous people who were working in funding institutions who actually had experience with policy and funding calls. I also talked to senior administrators in communities, so the directors of Indigenous community organizations. I talked to managers and program coordinators, as well as frontline staff, including elders who were providing mental health and wellness programming in those organizations to kind of get an idea of how contracting really shapes their everyday experience of providing care or programming. And so what the findings showed was that contracting really unfolded in a wider ideological context, which was really rife with structural racism and systemic racism. It was built predominantly on biomedical models of care instead of Indigenous models of care. And it was also bending to neoliberal healthcare reforms, which really emphasize efficiency and the adoption of market-based solutions in the public sector, such as contracting, contracting out, and also performance-based approaches to accountability. So what I will do next is I'll share with you a number of participant quotes that are from Indigenous participants to illustrate for you how those power relationships and structural inequities that operate at the macro really kind of operate across those different kind of levels to shape experiences and inequities. So here we have a quote from an Indigenous community participant who had worked, I know, it's a good quote, who had worked in community for more than 20 years. Was saying that really, while contracting is always kind of looked at as perhaps an equity promoting mechanism for Indigenous peoples, the funding distribution really didn't follow a need. Instead, there was a funding hierarchy, and Indigenous community-based services were really at the bottom of that funding hierarchy. And that funding hierarchy really reflected the dominance of the biomedical model in the healthcare system and in mental health care, as well as assumptions around race, class, even gender. Another finding at that level was that people talked about the kind of contracting models that were in place. So it was became very clear that the predominant model of contracting was one that was short-term, oftentimes only 1 year, not renewable, became increasingly fragmented, so smaller contracts. And many of them were distributed using a competitive tendering model. So there were requests for proposals, and then organizations had to submit proposals and compete against one another for oftentimes rather small sums of money. So all of those features that I just explained are very much features of neoliberal reforms. So that's something to keep in mind. And also, I guess something that's most notable at that level was that while literally all levels of government were engaging in contracting with Indigenous communities around mental health and wellness programming in the broader sense, there is not a single written policy that could be guiding this process for urban Indigenous peoples. So another area that emerged as being important was in relation to issues of recognition. So something that people in the community talked about a lot is that they were contracted to provide a culturally appropriate service, and it would be written right into the contract. But then when they looked at their budget, there was actually no funding allocated for any of those things that would fall outside what is usually considered in the biomedical sense a mental health service. So anything that had to do with cultural interventions or had to do with material to kind of create, say, a button blanket or star blanket or honorarium for elders, all of those things were not included in the contract, and so had to be actually covered by the organization in other means, but those are nonprofit organizations, so it's hard to actually get other funding to pay those aspects of your contract or your service that you are obligated to provide, but then you don't have the resources to do that. And it's quite interesting how organizations dealt with that. Some organizations, for example, collectively decided to take a pay cut for everybody. So it was actually like individual people working in those organizations who would shoulder this kind of responsibility rather than the state or the health authority to enable a service that they saw as needed in the community. Other issues arose in relation to participation, and it was quite clear that for many participants, they really didn't feel that they had a voice or any meaningful conversations with funders when it came to negotiating their contract. Oftentimes it was very one-sided. People also talked about the issue of not being meaningfully involved in determining and articulating what the actual problem is. So oftentimes the problem to be addressed was defined by people in policy that had very little understanding of what the problems on the ground are or what communities actually identified as a problem. And then a request for proposal would go out to address that problem that had been defined not by Indigenous community members themselves, but by people at the level of policy. So already creating a problem right there. Another way or mechanism in how participation in Indigenous self-governance and participation was constrained in contracting was through a performance-based accountability approach. So in the contracts, it would obligate providers to report on their performances that were outlined in the contract. So, and people talked about how those kind of requests became over time longer, they became stricter, and now as people who actually are providers and not really administrators have to spend a whole bunch of their time on reporting. And oftentimes that created problems in terms of how much time you can actually allocate to your care and to your patient when you have to kind of put so much time into actually reporting. And many felt that it was shaping, because certain things needed to be reported, it was also shaping how care was provided. And so in many ways, it was seen by some as a paternalistic reenactment of colonial policies that were really intrusive and going far into the boundaries of the organizations to shape internal processes and decision-making. So coming to the micro level of care, where care actually was provided. So it's really interesting to see how all of those changes at the higher level, like, for example, fragmented contracts translated into fragmented care, how like short-term contracting ended up in disrupted relationships of care, and how people had to increasingly fit into a box in order to actually gain access to a service, because the contract was narrow and you had to meet certain eligibility criteria in order to gain access. And with all the cost cutting that has been going on, you know, to see that what has been stripped away from the service, which was once a more comprehensive service, was things like food, which was highly important to community-based providers, because not only has food a cultural significance in many Indigenous cultures around feasting, it's also very important for people to establish relationships and be responsive to the inequities that are shaping the lives of many Indigenous peoples who are using those services. So for many, they just felt it was completely impossible, really, to ask people to sit, ethically impossible, to sit in a program when they hadn't eaten and to listen to whatever the health messages were in the program. And also, this is very specific to mental health and addictions. For many people who live with trauma, like building a trusting relationship is just so key to have an environment where you can open up and you kind of move forward in your journey towards recovery. So for many people who actually opened up during the interactions with those care providers, when the contract was ended and it disrupted their relationship, it was actually re-traumatizing. And so for many people, this really meant going back to their coping mechanisms that they had in the beginning, which oftentimes include substance use. And for this particular provider participant, he named that basically causing a slow suicide for a lot of people and that they were dealing with. So in some, examining contracting through Indigenous, community-based and partnered research really highlights Indigenous perspectives with contracting that have been largely overlooked, and it also sheds light on the ethical and political dimensions of contracting. And most importantly, it highlights some of the unintended consequences and potentially harmful consequences that come from something that we often think of as an administrative, technocratic, and perhaps neutral process. So those are issues that a regular analysis, contractual analysis probably wouldn't have highlighted. And there's very little written around that. It also highlights, and I think that's one of the key messages that came from this research, is that in order to promote culturally safe care at the level, at the micro level, it's equity-oriented health system transformations at the structural and system level are needed. And that might include actions such as the co-designing of a policy framework for urban Indigenous health and healthcare, It might include changing the funding model to one that is actually sustaining relationships of care that supports Indigenous self-determination. And it also includes adequate resourcing and compensation of elders, of knowledge keepers, and traditional approaches to healing. So, and I'm happy to take any questions at this point. I feel like I'm talking a lot. So if there are any questions at this point, please just throw them in. I'm happy to answer them. And if not, that's okay too. You can keep thinking and noting down your questions for the end. But then I will just move on. But keep in mind, you can interrupt me at any point in time. I would prefer this to be more engaging and interacting. Just that you know. So this second project is a project that involves four friendship and one Métis community center. Also in BC, in the interior of BC, and you can see here are the symbols and the names of the different communities that we have been working with. And it is a study that really looked at co-designing, co-implementing, and co-evaluating a telediabetes and obesity service. And I think before I go ahead, I just want to very quickly talk about the context. So for many urban Indigenous organizations, their experience is very similar to what we usually consider rural communities. And I'm sure you're aware of this. We're living in Prince George, which is an urban area, but we're really far away from a lot of healthcare services, for example. So while we have a lot of urban Indigenous people living in bigger metropolitan areas, there are also a lot of Indigenous peoples living in smaller urban communities. And so those people who live in smaller urban communities face a number of additional barriers that include, for example, not having access to internet services, either because there is no service available or you can maybe not afford having internet service. People may not be able to afford access to the new technologies that you need. They may not have the confidence and literacy to use digital health services. And there's also the reality for Indigenous people that there is such a prevalent racism in healthcare. And I think if you watch the news, you must be aware of how that shapes people's lives. It's just very common. And so we have a lack of cultural safety in our healthcare system. We have jurisdictional barriers for urban Indigenous people who don't have the same access to services that, for example, land-based First Nations communities have. And we also need to think about the historical distrust that continues to exist towards Western institutions, specifically the healthcare system, because of the colonial history of healthcare and other social institutions which are actually meant to help and support citizens, but in the case of Indigenous people have caused a lot of harm and trauma through such institutions as residential schools and Indian hospitals. And so all of those historical things and the ongoing racism, of course, have created a distrust towards the healthcare system. And so when we design or think about telehealth services, while telehealth can certainly help to reduce some of those barriers, otherwise, like telehealth doesn't necessarily address any of those barriers unless telehealth is co-designed with Indigenous communities. And unfortunately, that doesn't happen all too often. But in 2019, we had 5 urban and rural friendship Métis centers in BC come together, and they're allied with one health authority, Interior Health, and one university, which is the University of British Columbia, to apply for funding. And they got funding from HRI, and they started together on a journey to co-design, implement, and evaluate local telehealth services for people who live with diabetes and or weight management issues, and to do that in a way that really brought together Indigenous and Western ways of knowing, which is really something that's captured by the concept of two-eyed seeing, and a lot of you might be familiar with it, but it really means to kind of draw on the strength of both Indigenous and Western ways of knowing, and to bring that together basically for the benefit of all. And it is an Indigenous concept that was introduced by Elder Albert Marshall, a Mi'kmaq elder, and it's a concept that I think is very helpful when we work in the area of Indigenous healthcare. In addition, in order to pursue the idea of creating better access to culturally safe telehealth services for people with diabetes, we also decided we wanted to create a workshop for providers to increase their expertise around diabetes and obesity and cultural safety, so that just regular providers like family physicians and nurse practitioners could provide this high level of care for people living with diabetes, rather than having them to go through like a gatekeeper to actually, like, which oftentimes is the family physician, to get access to a specialist. And considering that a lot of these communities don't have access to a family doctor to begin with, obviously created a problem. And then the third objective for our research was to create and distribute a how-to guide for other communities that's really based on those communities' experiences, and that then can be shared with other communities who are interested in designing something similar. Yes. So what does that all mean? In reality, it meant we were working alongside Indigenous community members. We were working alongside Indigenous elders, healers, providers. We were working also with Interior Health and their providers, as well as people in leadership. We work with Indigenous physicians, endocrinologists, and students and research team members from universities, from different disciplines, including nursing and medicine. So a big team. And we have been working together for the last 3-4 years, trying to create and implement those different local telehealth services. And what is really essential in the way we are working together is that we're building relationships that are meant to last, that are based on mutual respect, they're based on mutual reciprocity and respect. And all of those, what that actually means, we have articulated in research agreements that we hold with each single community. And it's also something that we express when we co-design our tools, and in decisions around what kind of tools we're actually using. And when it comes to, sharing the results, who do we want to share it with? All of those things are decisions that have to be made with communities together. And in the end, it is whatever we have created, even, for example, the implementation toolkit or the how-to guide, those are resources that are owned by communities. They're not really owned by us, but are living with the communities. So here's a slide that shows our entire team. And I just want to draw attention to one particular person, who is Métis Elder Arlene Vitar Hewitt. And she has been our elder advisor on the project. And she's been amazing and really making sure we're following protocol throughout our research process to make sure we have an Indigenous perspectives on everything, even though we are having weekly meetings with community research liaisons and working in other ways closely together with communities. It's important to have a position that works at the university. And I think we were really lucky, and I'm kind of proud to say that we were able to make sure that Arlene was hired as an adjunct, or not hired, appointed as an adjunct professor at UBC, to really get recognition for the wisdom and work that she brings to the project. I also want to highlight the 3 communities who were actually able to launch telehealth clinics as part of the project. So that's the Little Red Friendship Center, the Caribou Friendship Center in Williams Lake, and then also the Métis Community Services Society, which is located in Kelowna. So it's those 3 organizations that were able to really lead the process in many ways. And despite a lot of obstacles that we encountered along the way. So not only did we have COVID happening at the start of this project, we also, as you know, many of you probably lived it yourself, we had wildfires, we had flooding, we had a lot of catastrophic, we had heat, we had extreme heat, especially in the interior. And so we had a lot of other things that impacted communities, including the discovery of unmarked graves at the former residential school in Kamloops, for example, and Williams Lake. And those events really impacted communities. And it is a reality that researchers need to take into account and understand that research isn't always a #1 priority for communities. And how you deal with this is something that you have to decide on an individual basis with communities, what they would like to do, if they want to move forward with the research or not. And in our case, we had 3 communities that decided that they wanted to move forward anyhow. And so we did. And so since 2022, those 3 communities have held more than 32 uniquely tailored telehealth clinics with a total of 21 community members. And it's with the direction of the communities that those kind of services were tailored to the specific needs of communities. So for example, it was very important for community members to create the first visit in a way that was really only focusing on relationship building. So there was no assessment going on, really. It was just about relationship building. It's also really important for community members to be able to bring a support person with them. And so people were really encouraged to do that. It was also important to have different pathways of how to connect with that service. So people could connect from home, or they could walk into their local friendship or Métis center and get support there to connect to the computer and the telehealth service for people who weren't really familiar with how to use computers, or for those who didn't actually have access to one, that kind of tackled those kind of problems. And the third option was actually something that never got realized at to this point, was for community members to go in and have the provider come in person to the community center, and then only have an Indigenous physician come in virtually. There was also, of course, what community members said was really important to them was to have traditional healing available for community members. And how that looked like was very different depending on the community. So what we ended up doing was actually giving communities the money to decide how they wanted to do that, to identify the trusted healer that they were working with, which was really different from one community to the next. And so one community, for example, had a local healer come and facilitate a group session for community members, but also for the providers, because they were really interested in having both sides learn. The traditional healer was actually very interested to learn more about the Western care and vice versa. So here we can just see some of the post-clinic service results, and you can see how powerful and positive the service was received by community members. You can see most people felt safe and comfortable during their visits. They felt safe and comfortable asking questions. And they also felt that they had been listened to and that their question had been answered. And also most of them actually knew what to do next with their self-management. And here are just few quotes from people who participated in the talking circles. Now I'll give you a little bit of time to read that. I highlighted those aspects that I think are particularly powerful. But we see that overall, what we found in the talking circles is that the telehealth clinics really enhanced their people's access to diabetes and obesity care. And they also supported people's subjective experiences of health and well-being. And a lot of it had to do because they were met where they were, like the providers met them where they were at. They created a really non-judgmental environment to talk with them. And they had a support person with them that enabled people to feel more courageous about sharing their experiences without being fearful of punitive treatment by the healthcare provider. And so with this, I think we can conclude the second project to say that really technology can be utilized to enhance equitable access to healthcare and equity in health with Indigenous communities, but only if it's co-designed in conjunction with Indigenous communities to ensure that those services are responsive to the unique needs, the priorities, and the context of those communities. Yeah, go ahead, please.
I'm responding to your invitation to ask questions.
Please
during, and I'll speak loudly, so I hope that the people online might be able to hear. There's so much to like about these projects. Thanks for sharing them, Vivianne, and I'm delighted that they'll be recorded so other people can watch them in the future. I've got some really specific questions. One is, not everybody knows what a friendship centre is, and I wonder if you could just elaborate a little bit on how that's such an important space to be engaging with. A second super specific question is the effort to make the elder advisor an adjunct, appointed as an adjunct professor, I imagine was quite a big story. And I'm just curious about whether or not that person is still an adjunct professor, and just sort of what if that's seeded off other examples in the institution where you were, in the sense of because the valuing in that way has lots of benefits. And I think my third question, which is a bigger picture one, and you don't need to get to this one, is I sort of wonder if the polycrisis of heat domes and wildfires and COVID and all the rest kind of in some ways, because you had a co-design process, actually created more kind of commitment and tenacity to make it work, because the needs would have been even more pronounced. So I just kind of wonder if sometimes the crisis can actually give people the courage to really figure out a path through. So 3 quite specific things.
Yeah, thank you, Margaret. They're all really good questions. So the first one was around what are friendship centers? For those of us who might not have a good idea of what those organizations are, there are organizations, I think I don't know, I think they started in the 50s, 60s, around that time. And there were organizations that were really meant to support Indigenous or First Nations people, specifically, actually, in that case, initially, who were able to leave their reserves when we were coming more and more into urban settings. And they were really meant as a place of belonging, place of culture in the urban setting for Indigenous people, and really helping people not to feel connected and find their community within cities, which they weren't really able to do before, because leaving reserves wasn't something that was strictly controlled really through policies. So really, when those policies kind of ended, it shifted the context, and people were actually free to go and move into cities, and so they did. And so friendship centers the role of friendship centers since has evolved a lot. And so a lot of these friendship centers today are providing a whole range of wide services, including like social services, health services, and increasingly are also really becoming involved in in policy making and actually being a voice for urban Indigenous communities who don't really have a representative body otherwise, who would be speaking on behalf of their concerns and issues. Yeah, so I hope that
That's great. Thank you.
answers. And there's also provision, there's a provincial, there's a National Association of Friendship Centers, and they're actually funded through federal money. And one of the key aspects of friendship centers is that they're serving everybody. So they're serving no matter whether or not you live on reserve, off reserve, if you're First Nations, Métis, or Inuit. If you're not even from Canada, they will serve everybody. Also people who are non-Indigenous. Yeah. And the second question was about the adjunct professor. And I actually am not aware of another case that was kind of inspiring us to do that. And at least not in, this is actually in the Southern Medical Program, so it's a UBC Okanagan campus. And yes, she's still an adjunct at this point. However, yeah, with the ending of the research project, some of the funding that flowed to her, and I mean, her role has kind of ended on the research project because the project has come to an end. So at this point, it might be more symbolic, but I hope that there might be, as I'm not at UBCO, I don't know how much involvement she has in terms of teaching, for example, but I can say from my perspective that I will invite Elder over to come and speak at some of the classes I'm teaching here in nursing. And I have already done so in the past, so. And then the third question.
You may not have time, but it was just that idea of the polycrisis making people more courageous.
Yeah, it may have, and it's most certainly impacted people in terms of their mental health a lot. Also, which kind of really shifted a little bit the focus of the telehealth project. People living with diabetes really talked about the need for connection, for mental health and wellness supports, for holistic care, and so that's actually something I'm taking on as a result of it, to kind of look at technology-enabled solutions to mental health and wellness needs for or in Indigenous communities. So something we're working on right now that came out of this. Sorry, how much time do we have left?
3:25.
And we have until
4.
Okay, so we won't have, there's not much left, but I just want to very briefly introduce the third project, which is called Weaving Wisdom, the co-creation, co-implementation, co-evaluation of a strategic framework for decolonizing nursing here at UNBC. This is just, of course, most of you probably are familiar with the fact that nursing schools have been called up on as much as medical schools to really take a hard look at their curriculum and see of what kind of voices they are actually amplifying and which voices have been silenced, and to make sure that we're recruiting Indigenous students, that we make sure that we retain students, and to really create a workforce in nursing and in medicine that is capable and committed to practicing in a culturally safe way. So when I started here last year, together with my colleague Sheila Blackstock, we decided we should probably take action. And we started with creating a committee, a standing committee in the School of Nursing, which is called Allies in Allyship. And we got support from the School of Nursing. We applied for some funding. And so we set out to begin our process, and in alignment with our theoretical perspectives, which are the same that I talked about in the beginning, we really wanted to take a community-based approach. So our first approach, our first step in really co-creating this vision, was to connect with community, Indigenous community in this case, and invite different First Nations, Inuit and Métis organizations and providers and community members to join us for a one-day gathering to explore two questions, which really were around what do you see as key priorities to be addressed in the School of Nursing, and what kind of actions do you want the School of Nursing to take in order to ensure that families and communities' needs are better met. And in order to do that, we were really specifically drawing on both Indigenous and Western methods again. We were using community gathering as one example of an Indigenous method. We're also using sharing circles. We're using Western surveys, small group discussions. We're using arts-based approaches such as artistic rendering to kind of capture our dynamics and conversations throughout the day. And we use democracy, and you can see this little picture here to the side as an example of how democracy looks like. It's an excellent technique to engage community members in setting and identifying priorities. And you just, in this case, we had listed the number of community identified priorities that people had mentioned in the sharing circles and the small group discussions in various different ways. And then you ask people to rank the different priorities by putting a little colored dot on the side of each little sticky paper. So each community identified priority. And we had like those that are high priority, those that are important, but more in the long term, and then also some things that were already going well. And here you can see that was what was captured, our journey throughout that day, all of the things we did, the things we discussed. I think it's a little small for you to kind of see everything, but get an idea of what a graphic rendering or artistic rendering of the day looks like as a different way of collecting data in research. And here you see some of the other methods we use. We also created a tree with root causes and root strength, and at the top being priorities and actions, inviting people to put little sticky notes down. You can see our team here. We had a number of students helping us out throughout the event. And at the very left of the photograph, you can see Teresa Healy, who was our artistic artist, who was kind of graphically capturing our discussion throughout the day. And what came from it is just, here are just a number of examples. And this is just looking at nursing education rather than practice and research, but already a number of priorities that came up, and people shared a lot and really emphasized the need for partners and engagement, for advisories, the importance of having mentorship models, of using role modeling and creating pathways to improve student recruitment and retainment, to have more Indigenous representation in nursing, the importance of actually having student voice included in the redesigning of curriculum. And of course, equity, diversity, and inclusion principles are also important for creating cultural safety, and to really focus on rural and remote and northern realities in our curriculum, and also apply a distinction-based approach. So while I oftentimes use Indigenous, the notion of Indigenous peoples to kind of refer overall to Indigenous peoples, actually oftentimes much more appropriate to refer to First Nations, Inuit, and Métis people. Each group has their own cultures, and there is a huge diversity also within each group. So it's really important to remember that, and when we teach, to make sure that we don't take this blanket approach and treat Indigenous peoples as one. People also emphasize the need to integrate more traditional knowledge and to talk about how to create relational safety. Yeah, and here you can see, just coming to the end of my presentation now too, you can see some of the reflections that people left when they left the gathering. And it was very well received. People found it was very powerful to have this voice. Really appreciated having this discussion with other community members that we listened. And it's really rewarding for us as well to see those kind of responses as we left the gathering. And hopefully we'll continue this good work into the future. We'll talk to more communities, engage students and faculty, and then have a vision that we can together implement and evaluate in the future. And with this, I just want to end it, and maybe I even like go back one step and just going to open it up, because I just wonder if we can have a discussion about what you think are some of the lessons learned from all of those projects. I have a list, as you saw. I think there are lots of benefits coming from those projects, but rather than imposing what I see as being the lessons learned coming from those projects, I'm just wondering if we can have a discussion about like what, where do you see the value in doing this kind of research?
You just leave the discussion, or would you like me to come up?
You can come up with me.
No, I just field questions, but it's to you. You're doing a good job. So.
I really feel we can do this together. So if
Well,
you want to come up here and do this with me, or like maybe read some of the in the chat. Do we have to leave this?
No, I think Bree can see the chat.
Yes.
Oh, okay, perfect.
But maybe I can start, or if any of the audience has any questions. I'm a bit curious. Well, talking about the next steps, but because you mentioned with the contracts and the health funding, that this fragmented funding equals fragmented care. So, we often think of that as well in research. We have these really great community-driven research or community-driven projects, and then the funding is over for that portion. And how do these actually live on in our communities?
Yeah, that's key. I mean, sustainability is something that's really important to communities, and that's something that they're asking about right at the beginning when you form partnerships. And I think it's a very important question that and key consideration in when you start building your research team even. And I think the lesson learned from my side is that first of all, if you have partnered research, you want to have partners who are in situations where they can make decisions, where they can inform and advocate for your project at the level of policy. You want to work hence with health system partners, health authorities, and of course you do want to have the buy-in from community, because all of this is needed in order to make sure you have a chance at sustaining the service beyond the end of your research project. Of course, this is no guarantee, but I think it'll be a high ask to ensure or guarantee sustainability at the outset of your research project. But that doesn't mean that you don't have to think about it very critically right from the beginning. So.
Any other questions?
Yeah, Margot.
I'm going to follow up on your query, and I'm interested if anybody else has thoughts as well about what some of the kind of lessons from the three quite different projects that all had different timelines. It feels to me that somewhere in there is some lessons around patience and courage, because this kind of work doesn't necessarily flow always in the timelines that you might anticipate or that funders might want, and can require you to deal with delays or issues, other priorities that are coming up, especially with everything else that was going on. But there's a certain amount of courage to think, to sort of hold to your convictions and say, okay, are we going to commit to focusing on lived experience and creating spaces to hear those voices. So those are some of the kind of lessons about the benefits of patience and courage. But my question back to you is, how did you cultivate the patience and courage to, what was it that fueled your willingness to work in this way?
I think it provides you with the most meaningful research that there is. I think it is research that addresses very complicated issues in a way that is actually producing knowledge that is actionable, that is critical, and can actually really advance, I think, equity in health, equity in healthcare. So it is messy. It oftentimes takes longer than other studies. But the relationships you build, the positive outcomes of the kind of work that we do are just at a personal level really rewarding. But they're also really powerful in terms of creating change in the long term. So yeah, I think that is what motivates me. My relationships, the experiences I make, and the things that I witness, that people in communities are able to do, are just really impressive. Yeah.
Thanks. I was just wondering, the telehealth project that you've done for the diabetes and the obesity, is it possible that it's applicable to other kind of disorders or something that a community is suffering from?
Absolutely. I think it's absolutely possible to use this model for other areas of health concerns. It doesn't have to be diabetes or weight management. And in fact, that is something that communities should identify, whatever their health priority is they want to see addressed. But as I said, like people were already speaking about the importance of mental health and wellness, and some people were suggesting to create perhaps a similar program for telemental health, like for mental health. And it could be telemental health, but it could be a lot of different things. Technology is like a really broad concept. So what that could look like, I don't even know at this point, which is why we engaging in literature review right now, very broadly speaking, looking at any kind of technology or technology-enabled solutions for addressing mental wellness needs from an Indigenous perspective. So including the determinants of Indigenous mental health, which in many ways are very similar to the general concept of social determinants of health, but there are some very unique aspects of Indigenous models of health and mental health, which emphasize the importance of culture, of connections to the land, self-determination, addressing racism, decolonizing. All of those things really are important determinants for Indigenous health. So we're looking at how technologies have been used to improve those determinants of health, and also mental health and wellness more specifically. And then we'll bring that back to communities and we'll have those kind of discussions to see what the fit is, what they would like to pursue, if any. So yeah.
Thanks.
No, it's just a thank you.
Okay, well, then I will just leave you with my thoughts, more of my thoughts. So I think what I learned from Indigenous community partnered health research is that there are excellent ways of forging new relationships and partnerships between different health system partners. They can improve sustainability of research beyond the end. Therefore, they can build relationships that are built on respect, reciprocity, and responsibility that look quite different to how relationships have looked in the past. So that can bring health and healing, I think. They also produce, as I said before, really meaningful and relevant research findings that are actually of benefit to communities and can be applied. Importantly, they also really foster a strength-based approach. So rather than kind of having this deficit discourse that continues to circulate and depict Indigenous communities as, sick and disorganized, those are opportunities to highlight the strength and the knowledge and capacities of Indigenous communities. And along the way, you can actually build capacity together in communities as well. They also help you to focus as a researcher on the diversity that exists among communities. So if you work with a community, it will tell you quite clearly, okay, this is different for us than to the community over there. And so by being informed by what community has to say and listening to them, you actually you just have to pay attention to diversity. I also think it really helps you to have a deeper analysis and understanding of the deficits of colonial institutions and practices, including, as I said before, the unintentional consequences, and to understand how power operates oftentimes in not very obvious way. And that is something you can get at when you actually listen to people who live those lives and realities. And then finally, I think it generates really actionable knowledge that is able to disrupt the status quo and to advance equity in health and healthcare. And it also creates new methodologies by really building up on the strength of both Indigenous and Western ways of knowing. Yeah, and I'm sure there are many more, but that's just something I came up with. So with this, I just want to say thank you. And if you have any more questions.
Well, from everybody online and everybody here in the room, thank you so much for coming and sharing with us today.
Very welcome. Thank you for coming and listening.
And we're glad you decided to stay here at UNBC and look forward to hearing your progress.
Thank you.
Some of this work.
Yeah, maybe if anybody's interested in any research assistant opportunities, contact me. It would be excellent to have more people on board.